In 2013, I was lucky enough to meet Abello, who showed me that he was making a shirt sleeve assembly with a polyethylene bag and a rubber ring. In 2014, I met Dr. Abello Britto, who did exactly the same. And it really was very, very inspiring. I was encouraged to change the polyethylene bag for a polypropylene one because it was infinitely finer, thinner, more transparent, and also had other properties that required us to test its resistance. Because it's so thin it looks like cellophane. It's not cellophane. And really at the beginning we needed to know that it was resistant. And it was very resistant. And it had another property, which is the property of thermosealing, of thermomolding at 70 degrees. And this allows us to imprison that rubber ring so that it does not come out of the bag, and not need to put it double, and then lose transparency, and to be able to add our tactile sense when palpating the intestine, because it is palpable perfectly through that bag. Before getting into the assembly tips, I want to add that I always like to call this device Abello Britto device because they came up with this gesture of assembling a shirt sleeve into a hoop. Since the last century they have been doing it. My only modification was to change the polyethylene bag, which is very thick and not very transparent, for a polypropylene one. And they, with that gesture, only told me that I already deserved to be called Abello Britto Svetliza. I laughed a lot and told them, at the most, let it be called ABS because that name is very difficult, and it remained ABS. Incredibly, it became popular under the name of ABS, and that is how it is known. After nearly a decade of trial and error with bag and hoop sizes, today I am able to tell you that a 5 by 10 inch bag is the proper size. I used to use a 10 by 20 or a 10 by 25 before. But I learned that the thickness of the rings must be 5 millimeters so that they are firm. And the internal diameters have to be from 4 to 6 centimeters. And heat sealing is a must. I highly recommend heat sealing because that way we avoid having to double the bag for fear of it coming out. Because the bag can really be unzipped when you need to leave the intestine in the silo for a few days. And one has to be sure that the bag is firm. So, heat sealing allows us to add tactile sense, since the bag is so thin that it allows us to touch it as if it were a condom, or even thinner, because they measure 50 microns. It allows us to exactly palpate the consistency of the intestine and allows us to see its actual color. And how do we select the right size? Well, we have already been measuring the diameter of the defect. So we know what defect that patient is going to be born with. And we know very well that if it has a defect, for example 20 millimeters, then we need the external diameter to be 50 millimeters. Because the external diameter has to exceed the diameter of the defect by about 30 millimeters. You think that we use this silo as a reduction instrument. This silo changed our lives, because before simul exit was to reduce, but hey, now we find that simul exit can be done to leave the silo. We use the ABS silo as a reduction instrument. What does it mean? That if by chance it is reduced easily, the external diameter does not matter, that it is just a little bit that exceeds the defect. But if you have to leave the silo, and you don't take this detail into account, that silo will be blown away. In order to avoid the pop-up or the loosening of the ring, the external diameter must exceed the diameter of the defect by about 30 millimeters. So in our Neo, we are going to have a box specifically made of material that we use in gastroschisis, where we have very different sizes of ABS silos, ranging from 4 to 6 centimeters, generally with an internal diameter. And just in case, because the patient who comes with a very severe peel is never missing, we also have Alexis type devices that are much larger. And we prefer not to use them. But exceptionally there are times when we have to use them. It is very, very important to know that if the hole is less than 2 centimeters, it must be opened. And it opens at the level of the fascia, at 12 o'clock. I always measure the ring in the prenatal echo, and I already wait for the birth with the scissors in hand when I know that the hole measures less than 20 millimeters. It is very difficult to place an ABS silo if the hole measures less than 20 millimeters. Another important tip is to remove the air from the silo. ABS must be used without air inside. Otherwise, an embolus is formed that not only makes reduction difficult, but can also add discomfort to the neonate when we exert pressure on the silo to reduce. And discomfort above all because it is very likely that air is injected into the abdominal cavity. Then we are going to take care of removing that air from the bag to prevent this inconvenience from occurring. But now we were going to reduce with the bag, with the ABS silo, so one of our concerns is the fact of not generating iatrogenic rotations of the intestine during the act of reduction. And the best way to prevent it is by collecting the eviscerated intestine, respecting its natural fall. That is to say, to avoid carrying the intestine up the bag, rather it is going to pick it up just as it came out. But then I show them how it should be, how we do it. A bag without air, we collect the intestine, or we always start with the sentinel loop, right? And we only collect elements that correspond to the midgut. Normally the stomach is the most constant element to reduce, before entering the hoop into the abdomen. The reduction of the stomach must be accompanied by aspiration of the oropharynx, especially if this gesture is done hours after birth. We don't have this problem because we use the simul exit operative. But when a referred patient comes in with a diagnosis of gastroschisis, we are going to find the entire mid-intestine inflamed, we are hardly going to recognize what it is, and we are going to see that the stomach is also outside, normally with little or no inflammation. Well, when the stomach is reduced, be careful that a mouthful of gastrobilious content will come to flood the oropharynx. And once we reduce the stomach, I say stomach because it is the most frequent, because there may be genitals or the bladder or the gallbladder. Well, once we reduce the stomach, we give it a boat shape, let's say a little point, with our fingers, between the thumb and forefinger. We shape it, we make a point that enters at the 12th hour. Let's see it graphically. In this short clip we are going to see that once the stomach enters, it is shaped, a tip is made with the ring. And once that tip enters, this penetration is digitally and circumferentially accompanied, which is usually completed very quickly. Patients with poor prenatal follow-up may require gentle, digital release of the entire circumference of the defect. It is very common to find loose adhesions that will yield very easily. But be very careful, because there are times when we find very obvious ties. And when these ties are present, I recommend tying them one by one, the old-fashioned way. Trying to avoid the use of electrocautery because one of these flanges has ever conducted heat and perforated the intestine. So, if the risk of bowel perforation due to heat is 1 in 10 million, it better be 0. That's why I recommend not using electrocautery for these purposes. When we have patients with moderate to severe peeling, we know that we are going to have to leave the silo. A gentle pull toward the zenith is essential, because this traction is what will allow venous and lymphatic drainage and is essential in delayed reduction. The traction rubber ring favors the opening of the defect, alleviates the strangulation that the entire system of mesenteric vessels was suffering. In this way, immediately it is as if it begins to deflate. Even in the first hours we can see the liquid inside the bag. And again, I'm going to show you in graphic form how it goes down in a few hours. It begins to collect liquid. When my friend Arnaldo from Guatemala invited me to talk about comprehensive management of gastroschisis at his Roosevelt Hospital, the talk was going to be at 8 in the morning, but he told me first we are going to see a gastroschisis that has just been born. He had already been born for an hour. So at 7 in the morning we made contact with that patient who had been born at 7 in the morning. I fixed. And we had to put an ABS silo with a slightly larger ring. Obviously I had to solve several zip ties, which I tied them the old-fashioned way. But we did this with morphine rescue, not with general anesthesia. I had to enlarge the defect obviously. And we left that little bag that was practically under pressure. That 12 by 25 bag was under pressure. I went to the auditorium, we gave the talk. We came back at about 3 hours, and we already found that you could see the handles that you couldn't initially see. Now through the bag we could see them. And look, This creature was able to go home at 35 days of life, without a single stitch and without general anesthesia. He was able to go home at 35 days of life, because all that terrible pseudocapsule was handled gently, all that terrible serious peel. The ABS silo is spectacular, yes, but it is not commercial, it is handmade, does not work alone. You have to be on top of the entire process that derives from its placement, which will also be handmade. This thermal moldable property of this bag means that the patient's own heat, at 37 degrees, can generate this mushroom-shaped deformation. You have to be very high. We have to go to recover the shape of the bag, exerting gentle pressure. You know that pressure is force on surface. And when we squeeze the bag, the intestine receives the pressure evenly distributed over its entire surface. And this will favor the gradual introduction into the abdominal cavity. And this is a difference with commercial silos, where one expects the force of gravity to act alone. Here it would be a mistake to wait for only the force of gravity to act. Here we have to intervene artisanally and sequentially, because if not, the vector forces that would direct the reduction of the intestine towards the abdominal cavity are discretely diverted when the bag is deformed. We have to go and modify those vector forces in an artisan way. When we have to do a deferred reduction, we know that it is optimal to do it every 12 hours. But in reduced services like ours, we can hardly go every day, once a day. We do it under rescue with morphine at a rate of 0.1 mg kilo dose. And we know well that we have to try to reduce that intestine in 3, 4, or 5 days, maximum 6, because when the intestine remains for more than 6 days it becomes caked, it adjusts to its new situation and adhesions form that become more and more firm, forcing us to undergo surgery, that is, take him to the operating room and perform surgery, which was what we did not want to do. And an obvious question is, how do we control intra-abdominal pressure during reduction gestures? Well, we already explained it. We use non-invasive monitoring of abdominal pressure. And really not only that we see the issue of oximetry, but we already have the ear, and we know how far we can do, without generating pain. Because the heart rate immediately skyrockets when we are doing more than what needs to be done. And there we finish the procedure for that day. Well, we also have a tip for removing the ABS, because, be careful, if it comes out with a simple pull, it's simply because we didn't use the right size. Be very careful with that. They will not be able to remove it with a simple pull if they use the correct size. That is to say, it pulls and part of the intestine will also come out and it will be a mess. So the tip is the gesture of the fisherman. So you're going to go in with a Halsted forceps, pointing the tip of the forceps up the curvature. And we are going to palpate the outer edge of the rubber ring at the same time, and we are going to feel when the tip of the Halsted forceps passes the rubber ring. This is the way. Then we turn the tip until it hooks the rubber ring, and we bring it towards the defect. We take it with our hands or with another clamp, and thus the procedure is finished. We will see this graphically. Notice, we go in with the Halsted point up. We feel. In this case, with my thumb I am feeling everything. And when I overshoot, I hook it up, I pull it out. And in my case, I take it out with my hands, with my fingers. And with other fingers, I take care that the intestine does not come out. I hope all this content has been useful for you. However, I'm sure you know someone else who could help. So don't stop sharing it, and subscribe to my channel.